Have you ever felt that subtle, almost imperceptible shift in how someone sees you just because they learned something about your health?
Mm,
Or perhaps you've noticed how some diseases carry this weight, a social burden far beyond their physical symptoms.
yeah, definitely.
That complex, often invisible world of shame and blame in health is exactly what we're diving into today.
That's right. Today, our deep dive is all about health-related stigma.
Okay.
We're going to explore where this idea comes from,
Mm-hmm.
how our understanding of it has dramatically changed over time, and most importantly, what it means for people and for society right now.
Our mission then is to cut through the noise and extract the truly vital insights from a landmark piece of research. Graham Scambler's comprehensive review, Health-Related Stigma, published back in 2009.
Right, it's a really foundational text.
Hmm.
Scambler's work synthesizes decades of thinking, so it gives us a great shortcut to understanding the profound, often hidden impact of shame and blame in health.
Okay, so let's start at the beginning. How does Scambler and the field he reviews actually define this powerful concept of stigma?
Well, at its core, stigma is seen as a social process.
Hmm.
It's something you either experience directly or you anticipate happening.
Okay.
It shows up as exclusion, rejection, blame, or even just being devalued by others.
Hmm.
And all of this comes from a negative social judgment made about a person's or maybe a group. Now, this judgment is based on an enduring feature, often a health problem or some related condition.
Uh,
And here's the crucial part. This judgment is, in some essential way, medically unwarranted.
Medically unwarranted. Okay, that's key.
Exactly. It means it has no basis in actual medical fact. And it's not just about individuals. This discriminatory judgment can also attach to the disease itself, and that can directly influence public policy.
That medically unwarranted distinction really jumps out. So it's not the illness itself that's the problem, but this unfair societal judgment layered right on top of it.
Precisely.
And the word stigma itself has such a vivid origin, doesn't it?
It absolutely does. The word stigma comes from ancient Greece, from stig, which meant to prick.
To prick.
Yeah. Back then, a stigma was a literal mark, like a tattoo branded onto slaves.
Wow.
It was a physical sign to brand them as property, as outsiders, really designed to prevent escape.
So it's a very visible mark if someone cast out. But today, that mark is usually invisible, right?
Exactly. Today, the mark is more often invisible. It implies a disapproval or a disgrace that allows insiders to identify and distance themselves from outsiders,
Okay.
reinforcing the perceived normalcy of the dominant group. It's how society subtly draws lines between us and them.
And when we talk about those lines, those relationships, we really have to talk about Irving Goffman. His 1963 book, Stigma, The Management of Spoiled Identity, is just iconic.
Absolutely.
What was his big contribution to understanding this invisible mark?
Goffman's work was truly groundbreaking because he emphasized that stigma isn't just about an attribute a person has. It's fundamentally a language of relationships.
A language of relationships.
Yeah. The same attribute that stigmatizes one person might be completely normal for another. It's always about context, how an individual is perceived and treated within specific social interactions.
And he also made a really useful discussion between people with obvious stigmas and those with hidden ones, didn't he?
Yes, that's a key insight. He talked about the discredited versus the discreditable.
Okay.
The discredited are those with visible marks, like, say, a physical disfigurement. Their challenge is managing impressions in public because their stigma is immediately apparent.
Right.
The discreditable, on the other hand, have invisible marks, like a hidden illness.
Mm.
Their challenge is managing information, deciding who to tell, when, how, to avoid being found out.
He viewed social life almost like a performance, didn't he? Like we're all actors on a stage.
That's his famous dramaturgical perspective. He believed we all present a carefully constructed face in what he called front regions.
For public settings, like a clinic you mentioned.
Exactly. But then we can relax that performance in back regions, like maybe a hospital canteen or just at home.
Right.
For Goffman, your sense of self is actually shaped by this constant social control, by how you present yourself and how others react to that presentation.
So Goffman's insights were profound for individual interactions, clearly. But what was still missing from his framework when we consider the bigger picture?
Well, while Goffman was brilliant at describing those individual interactions, critics argued he didn't fully account for the causal input of larger social structures.
Ah, okay. Things like,
Things like economic class, gender, ethnicity, or a society's core beliefs. These powerful forces weren't really central to his analysis. These social structures act almost like invisible rules, shaping the very interactions Goffman observed, and he didn't fully explore their pervasive influence.
And that takes us then to what Scambler calls the personal tragedy or deviance paradigm, which became quite influential in medical sociology starting around the 1970s.
Right.
This approach really seemed to put the focus squarely on the individual's experience, didn't it?
Exactly. This way of thinking tended to view chronic and stigmatizing disorders almost entirely through the lens of individual experience and adjustment, as if the burden was solely on the person to adapt to their condition.
This is where labeling theory came in, particularly Thomas Scheff's work around mental illness. How did that fit into this paradigm?
Scheff's 1966 theory was quite controversial. He argued that the act of labeling someone as mentally ill could actually be a significant cause of mental illness.
A cause, not just a result.
Right. He suggested that when unusual sort of residual rule-breaking behaviors came to public attention and a person was given a psychiatric diagnosis, they could internalize that label
Huh.
and then begin acting in accordance with it, creating what he called secondary deviance. Now, later scholars debated how much this truly caused illness.
Sure.
But labeling theory profoundly influenced how we thought about the social impact of diagnosis. It shifted the focus a bit.
And within this framework, there is also a lot of focus on the internal experience of chronic illness itself. Concepts like biographical disruption or a loss of self come to mind.
That's right. Researchers like Burry and Sharmas highlighted how a chronic illness could fundamentally shatter an individual's life story and their sense of who they were. People often needed to embark on what Williams called a narrative reconstruction, basically trying to make sense of this new, often unwelcome, deviant career that their illness had imposed. It was all about the individual's journey to adapt.
Let's look at a couple of real-world examples Scambler draws on, starting with epilepsy. What did early research by Schneider and Conrad in the U.S. reveal?
Their 1983 work explored different ways people adapted to living with epilepsy. They found some were adjusted, managing to kind of neutralize the condition's negative impact,
Okay.
while others were unadjusted and felt really overwhelmed. Interestingly, among the adjusted, they identified quasi-liberated types.
Quasi-liberated, what does that mean?
These were people who actually publicly proclaimed their epilepsy, often to try and destigmatize it. This really foreshadowed later ideas about resistance and advocacy.
Huh. And then Scambler himself, with Hopkins in the UK, developed the hidden distress model for epilepsy. This sounds like a crucial shift.
It was. Their 1986 model made a critical distinction. Enacted stigma?
That's the overt discrimination, right? Like being denied a job.
Exactly. But then there's felt stigma, which is an internal sense of shame and the constant fear of encountering that enacted stigma.
Ah, the fear of it.
Yes. And crucially, they found that felt stigma was often more disruptive and emotionally taxing than actual enacted discrimination.
Especially.
For people whose seizures were well controlled.
So the internal burden was immense, even without direct discrimination happening all the time.
Precisely.
And it wasn't just the individual carrying that burden. Goffman also spoke of courtesy stigma, where stigma could kind of spread to those associated with the stigmatized person.
Exactly. A good example Scambler mentions is Gray's 2002 study on parents of children with high-functioning autism.
Okay.
It showed how these parents experience both felt and enacted courtesy stigma. Even though their children might seem normal to many observers, the stigma of association was very real for the parents, impacting their own social interactions.
Another powerful case study in Scambler's review is HIV/AIDS. Alonzo and Reynolds, back in 1995, proposed an HIV stigma trajectory. What did that model show us?
They outlined 4 phases of stigma that often link to the disease progression. It started with the at-risk phase, where people were worried about testing, maybe avoiding it.
Right.
Then came diagnosis, where individuals confronted this really altered identity. The latent phase involved living between health and illness, often concealing their status.
Which must carry a huge burden of felt stigma.
Absolutely. A heavy price. Finally, the manifest phase, where biological death became maybe more imminent, but the isolation due to intense felt stigma could still be a profound, separate experience.
In building on that hidden distress model, Stewart and colleagues worked with HIV in 2008. What did they add?
They expanded the framework. They introduced felt normative stigma. That's the subjective awareness that motivates people to avoid enacted stigma.
Okay, so managing the risk.
Exactly. And internalized stigma, which is self-stigma, where the individual actually accepts the discredited status as valid for themselves.
Wow, yeah.
They also noted vicarious stigma, where people learn about stigma and anticipate it by observing others' experiences of discrimination.
This all sounds incredibly complex, which leads me to an important question. How do you even begin to measure something as nuanced and internal as stigma?
It's immensely challenging. Van Brakel, in a 2006 review, identified 5 main approaches people were taking.
Okay, like what?
Things like surveys of public attitudes, audits of actual discriminatory practices, interviews about people's real experiences, studies focusing on perceived or felt stigma, and finally studies on self or internalized stigma.
So different angles.
Different angles. And while Van Brakel suggested it might be possible to develop generic measurement instruments that could work across different conditions and maybe even cultures, he cautioned against believing you could develop a generic theory of health-related stigma.
So you might be able to measure how stigma plays out similarly in different places, but not necessarily why it arises or what its fundamental causes are, which could be very different.
Exactly right. The shame connected to, say, HIV/AIDS might have similar measurable outcomes across cultures, but its roots could be embedded in entirely different structural and cultural relations.
Right.
There's also the danger of oversimplifying stigma, turning a subtle, dynamic human experience into just a simple variable that loses its depth.
That distinction between measurement and theory feels really important. And this brings us to a major shift Scambler highlights. Moving from that personal tragedy approach to what's called the oppression paradigm.
Yes.
What did medical sociology miss by focusing so much on the individual?
It missed the powerful influence of those larger social structures we talked about earlier. Disability theorists, especially from the 1980s onwards, really championed this oppression paradigm.
Okay.
They fundamentally shifted the focus away from the labeled individual and onto the labelers themselves, and, more importantly, onto the systemic structures that actively create disadvantage.
And the social model of disability was a huge catalyst here, wasn't it? Michael Oliver's work.
Yes, absolutely. Oliver, in 1983, made a revolutionary argument. Disability isn't primarily a consequence of impairment, meaning a deficit in the body, but rather of the social restrictions imposed upon people with impairment.
So things like inaccessible buildings or discriminatory attitudes.
Exactly. Individual biases, inaccessible buildings, unfair workplace practices, exclusionary attitudes, all of it. This wasn't just a theoretical shift. It was an urgent political call to action, demanding changes to society itself, not just asking individuals to adapt.
This is where it gets really interesting. Iris Marion Young's 1990 work on the 5 faces of oppression offers an even more refined lens for understanding this outsider status and what's sometimes called disablism. Can you walk us through those faces?
Young's framework gives us really powerful tools to see systemic disadvantage. First, she talks about exploitation, which is about one group benefiting unfairly from the labor of another. Second, marginalization, where people deemed useless by the labor system are pushed to society's edges. Third, powerlessness, where the autonomy and capabilities of some are deliberately undermined by others in positions of authority.
Right.
Fourth, cultural imperialism, where a dominant group's beliefs and experiences are treated as universal, making others feel invisible or deviant.
Okay.
And finally, violence. This isn't just physical harm, but also systematic attempts to humiliate, harass, or even eliminate groups considered beyond the pale.
These faces really bring to life how pervasive and structural disadvantage can be. So how does this understanding translate into a reframing of stigma and deviance in contemporary sociology?
Well, Link and Phelan in 2001 were central to this. They argue that stigma isn't just about labeling and discrimination. It co-occurs with these things, and for it to truly manifest, power must be actively exercised.
Power is the key ingredient.
It's essential. They ask critical questions. Do those who might stigmatize actually have enough power to make differences resonate in public culture? To connect stereotypes to people, to effectively separate us from them? And most importantly, do they have the power to control access to vital institutions like schools, jobs, and healthcare? They made it crystal clear. Stigma fundamentally relies on social, economic, and political power.
So power isn't just a backdrop. It's central to stigma's very existence and its impact.
Absolutely. And Parker and Aggleton, focusing specifically on HIV/AIDS, echoed this, noting that stigma really functions at the intersection of culture, power, and difference. It often serves to promote dominant group interests and reinforce existing hierarchies.
And Scambler herself introduces a crucial conceptual shift here, distinguishing between stigma and deviance. What's the difference there, according to him?
This is a really vital analytic distinction he proposes. Stigma, for Scambler, refers to an ontological deficit.
Ontological, meaning about being.
Exactly. A perceived flaw in a person's being. It reflects infringements against norms of shame, a feeling of being imperfect.
Okay.
And deviance. Deviance, on the other hand, refers to a moral deficit. It reflects infringements against norms of blame, a feeling of having behaved immorally or done something wrong.
So one is about who you are, and the other is more about what you've done or what society thinks you've done.
Precisely. And he even expanded on the earlier enacted and felt types, adding a project form.
A project form.
Yes. Working with Paoli in 2008, he introduced project forms, showing how individuals aren't just passive recipients of stigma. So you have enacted stigma deviance, the overt discrimination based on being imperfect or immoral behavior.
Right.
Felt stigma deviance, that internal shame or blame and the paralyzing fear of experiencing the enacted form. And project stigma deviance. This is the conscious rejection of those attributions of shame or blame. It signifies active resistance and defiance.
Ah, people pushing back.
Exactly.
And this all plays out within existing social structures, not in some kind of vacuum.
Definitely not. Norms of shame and blame and the labeling processes that go with them are always deeply embedded within a structural nexus, as Scambler calls it.
A structural nexus.
Meaning they follow society's existing fault lines of inequality. Research consistently shows these norms tend to align with existing social structures like class, gender, ethnicity, and so on.
Can you give us a real-world example of how these concepts, especially how stigma can transform into deviance, play out today?
Yeah, a compelling example Scambler discusses involves the British welfare to work programs aimed at people with chronic illnesses or disabilities. Now, while these programs aim to help people get jobs, Scambler's analysis suggests that under the neoliberal pressure to contain labor costs and cut welfare spending, the stigma associated with chronic illness can subtly be transmuted into deviance. Individuals might feel pressured to constantly prove they are not culpably deviant by not working or by not trying hard enough.
So the focus shifts from supporting them to policing their efforts, framing lack of work as a moral failing rather than a result of illness or circumstance.
Exactly. It shows that stigmatization is rarely the only ingredient of disadvantage. It's often intertwined with exploitation, powerlessness, and other forms of oppression within broader economic and political systems.
That's a powerful illustration of how deeply these structural issues run. So when we think about stigma reduction, what does this broader, more nuanced understanding tell us about the effectiveness of typical interventions?
Well, it suggests that many current stigma reduction programs, while often well-intentioned, are still largely biomedical and individualistic.
Meaning they focus on information or individual coping?
Right. They focus on things like providing information about a condition or boosting an individual's self-empowerment. And while these things can have some value, Scambler argues they're often more like damage limitation exercises.
Why damage limitation?
Because they don't fundamentally address the systemic, structural roots of stigma. The power dynamics, the cultural imperialism, the marginalization.
So it's not enough to just tell people stigma is bad or you can overcome it. It needs to be much more contextual, much more structural in its approach.
Precisely. Truly effective interventions must be reflexive, meaning they adapt to the specific situation and cognizant of context as well as social structure.
Right.
I mean, think about the stark difference Scambler highlights in the lived experience of HIV/AIDS between, say, a university professor in Los Angeles with access to the best retroviral therapy versus a 15-year-old seropositive girl who's been trafficked into a brothel in Bangkok. The interventions needed, and what's possible, are just not equivalent. Their effectiveness hinges entirely on understanding those underlying structural realities.
And there's even a twist with co-stigmas, right? Where one health condition might actually be less stigmatized than other associated behaviors?
Yes, that's a really interesting finding.
Yeah.
Chan, in 2007, found that in China, behaviors like drug use and commercial sex work could actually elicit more negative responses than HIV seropositivity itself.
Huh. So targeting the HIV status alone might miss the bigger picture?
It might. This suggests that sometimes the most effective interventions might need to focus on those risk behaviors or the context around them rather than just the health condition itself.
Yeah.
It just reveals the incredibly complex layering of stigma in different social contexts.
Now, to bring this deep dive toward a close, we have a fascinating, and I'd say even provocative, question posed by Bayer in 2008. Is stigmatization always a threat to public health?
Yeah, that's a controversial one.
Are shame and blame invariably something we should try to eliminate entirely?
Bayer provocatively suggests there might be, perhaps, Rare occasions when mobilizing stigma, for instance, around behaviors like smoking, could actually help reduce those risk behaviors for public health benefit.
Using stigma as a tool.
Potentially. Of course, the powerful counterargument, as Bayer acknowledges, sees this as a potentially barbaric form of social control, an unethical way to manipulate behavior by leveraging shame.
Right. It's a very fine line, ethically.
Extremely fine. And this debate really powerfully illustrates why we absolutely cannot neglect the social structural underpinnings of cultural norms and individual choice.
Yeah.
It forces us to ask really tough questions about the ethics and implications of how society influences behavior, both positively and negatively.
So what does all this mean for you listening? We've journeyed from ancient branding marks all the way to modern sociological theory. We've seen how stigma has evolved from maybe a simple concept of shame into this dynamic, multi-layered social process that's profoundly shaped by power, by culture, and by deep social structures.
That's right. We've explored that critical shift from focusing on individualistic, personal tragedy narratives to a deeper understanding of systemic oppression, and also Scambler's vital distinction between stigma, about shame and being, and deviance, about blame and behavior.
Understanding health-related stigma isn't just an academic exercise, is it? It's really about recognizing how societal norms, how power dynamics, and how our collective judgments can profoundly impact individual lives.
Absolutely. It influences access to healthcare, the support people receive, and even shapes the success or failure of public health initiatives. It reveals these often invisible forces that can really shape our realities and our health outcomes.
So as you go about your day, maybe consider where you might see these faces of oppression that Young described: exploitation, marginalization, powerlessness, cultural imperialism, and even violence at play in how different health conditions are perceived and treated in our society.
Yeah, it's a useful lens.
And ask yourself, what role does our evolving understanding of shame and blame play in shaping a more equitable and hopefully more informed society?